Welcome to the Explainer. Okay, we're cutting the fluff right out of the gate and jumping into a super high-yield approach for the NCLEX. Today is all about cracking the code on maternal and newborn foundations. We're going to zero in on exactly how to think like a nurse and, more importantly, how to dodge those really tricky exam traps. Let's actually kick things off with a quick scenario. Picture this. A patient walks in, reporting extreme fatigue, morning nausea, and a missed period. Is she definitely pregnant? Well, beware, because this is a classic NCLEX trap. It's perfectly designed to see if you're going to jump to conclusions. Rote memorization just isn't going to cut it here. You absolutely have to understand the clinical weight of these symptoms. Why does this matter for the exam? It's simple, really. Distinguishing between a presumptive sign and a positive sign prevents fatal test errors. If you just assume a patient is pregnant based merely on their subjective feelings, you could end up initiating the entirely wrong nursing intervention, and we definitely don't want that. Moving right along to our first section, Core Concepts, Reproductive Cycles Simplified. What's really cool to see here is how tracking these hormones aligns so perfectly with the physical changes happening in the body. If you consider the anterior pituitary hormones, that's the FSH and LH up top, and then the ovarian hormones, the estradiol and progesterone below, there's a clear pattern. Right at day 14, you get this massive spike in LH, and that directly triggers ovulation. Connecting those hormonal peaks to the actual physical release of the follicle, that's going to make pattern recognition an absolute breeze when you're staring down a tough multiple choice question. You gotta keep your phases separated so you don't mix them up on test day. Let's draw a hard line here. The uterine cycle has 4 distinct phases: menstrual, proliferative, secretary, and ischemic. Now, the ovarian cycle runs parallel to this, but it's categorized into just 2 main phases, follicular and luteal. So, burn this little rule into your memory right now. 4 for the uterus, 2 for the ovaries. Now let's talk about the dramatic estrogen drop during menopause. Notice the stark visual shift, representing the drop from age 40 down to age 60. And hey, this isn't just about hot flashes. This massive estrogen deficiency completely alters a patient's risk profile. As a nurse, your priority has to instantly shift toward advocating for essential cardiovascular and bone density screenings. Okay, let's shift gears into Section 2, Priority Alerts, Infections and Disorders. Here, we're looking at pelvic inflammatory disease, or PID, and toxic shock syndrome, TSS. These are severe infectious disorders of the reproductive tract. I want you to treat these as high alert conditions. They frequently pop up on exams because they require absolutely immediate recognition. You do not wait and watch with these, you act. Prompt nursing intervention here is totally critical to prevent long-term complications, especially infertility. The structural damage happening with the intensely inflamed uterus, the swollen ovary, and that massively swollen fallopian tube is intense. Without rapid treatment, we are looking at irreversible scarring. So pause and think for a second. Let's say you get an exam question detailing a patient with a sudden high fever, severe pelvic pain, or signs of a systemic infection. What is your very first absolute priority move as the nurse? The answer? You always default to safety, vital sign stability, and rapid infection control. Your number one priority is to assess those vital signs for any indication of impending shock. We're looking for things like a dropping blood pressure or a rapidly spiking heart rate. Next, you need to identify the infection source and prepare for immediate antibiotic administration. Literally never delay antibiotics in a suspected systemic infection.
All right, moving on to Section 3, Contraception and Memory Tricks.
The trick here is grouping these into 3 visual chunks. It makes recalling this massive list of family planning options so much more manageable when you're under exam pressure. First, we have our natural family planning methods, things like abstinence and tracking basal body temperature. Then the barrier methods, like condoms, spermicide, and diaphragms. And finally, the hormonal methods, which include combined oral contraceptives, patches, and IUDs. By anchoring these lists to visual categories, your brain can literally just snap to it and quickly eliminate the distractors on a multiple-choice question. When you see a word like diaphragm or sponge, you should instantly visualize that barrier category in your mind. It completely stops you from second-guessing yourself when that exam anxiety inevitably kicks in. Now, if contraception is one end of the spectrum, infertility is the exact opposite. But remember this key rule. An infertility evaluation always requires parallel workups for both partners. And you have to start with the least invasive methods. You wouldn't just jump straight to a laparoscopy for the female partner before doing a basic, totally non-invasive semen analysis for the male, right? Always step logically from least invasive to most invasive. Section 4 already. Let's get into the 3 Ps of pregnancy signs. Conceptually, you're moving step by step from the patient's subjective feelings to undeniable, objective proof of a fetus. Step 1, presumptive. These are things the patient physically feels: amenorrhea, fatigue, quickening. Step 2, probable. These are the things the examiner actually observes, like abdominal enlargement or Hagar's sign. Sure, they strongly suggest pregnancy, but they aren't definitive proof. Then we hit step 3, positive. This is undeniable. It's hearing the fetal heart sounds or visualizing the fetus on an ultrasound. Let's put this into practice with Section 5, a mini NCLEX scenario. Okay, I want you to read this charting carefully and look for the specific keywords we literally just reviewed. The patient's chart notes: amenorrhea, fatigue, and quickening. Then, on your physical exam, you note uterine enlargement. Take a moment to think about it. Are these findings presumptive, probable, or positive signs? Well, let's break it down. Amenorrhea, fatigue, and quickening are all felt by the patient, so that's presumptive. The uterine enlargement, that's observed by the nurse, so that makes it probable. But notice the trap here. There are 0 positive signs. Absolutely no definitive proof of a fetus yet. Section 6, time for our rapid-fire NCLEX recap. If you can internalize these patterns, I promise you're going to navigate maternal and newborn questions with incredible confidence. Remember, keep your 4 uterine and 2 ovarian phases totally distinct. When you see TSS or PID, your brain must immediately jump to assessing for shock and prioritizing infection control. Chunk those contraceptives into groups to save your memory. And finally, always step methodically through those 3 Ps. Never, ever assume pregnancy without definitive, positive proof. So, here's a final thought to leave you with. If a patient presents with presumptive signs but a completely negative ultrasound, what's your very next nursing priority? Keep that question in mind as you study, and remember to always think like a nurse first. A negative ultrasound with those presumptive signs, it could point to entirely different underlying health issues that really need your critical thinking skills. Anyway, thanks for joining me in this explainer. Keep pushing, stay focused, and I'll catch you next time.